Now, I invite Dr. Ishan PANDYA, for his talk on comparison of modern day EDOF and their outcomes.
Yes, a very good morning to all of you. I am Dr. Ishan PANDYA, and currently I am a consultant cataract and refractive surgeon at Satvika Hospital, Vadodara. So I have no financial interests to declare. So basically, all of this started way back in 2021 when we decided to understand what our patients, how happy they were with their vision. So basically, when we did a study asking them about how happy they were, we found out that 50% of our patients were satisfied with their distant and the near vision quality. Even if they had to wear some specs for their near vision, they were quite okay with it. What we found out was 40% of our patients had complaints for their functional near vision loss. They felt that the requirement to wear glasses was a problem for them. And when we talk about the functional near vision, we are talking about specifically works like doing their beard or reading newspaper, reading books, reading holy scriptures. And while 10% of our patients were dissatisfied both with near and distance vision. So basically, we decided to dwell a little more deeper on what lenses we were using, and we found out that 80% of our patients were given monofocal lenses. And only 20% of these patients were given the presbyopia correcting IOLs, out of which 10% were the advanced monofocals and 10% were the trifocals. Now, as a refractive surgeon, I essentially believed that all of our patients should at least have some functional near vision, and if possible, we should also, clear off their requirement for near glasses also. But since some of the patients would not be eligible for trifocals, we focused on converting most of our monofocal practice into advanced monofocal practice. So basically, we had our qualms. We were doubtful, would the advanced monofocals have the problems of loss of contrast sensitivity? Would these lenses have the degradation of the nighttime quality of vision? And most importantly, would there be a cost to the patient that would be a factor in us not being able to use these lenses? So similar queries were raised in an ESCRS trial in 2020, where the doctors there also had some similar questions. So for this reason, we decided to take up this study where we decided to operate at least 150 patients, wherein we will convert them from monofocal to advanced monofocals. We'd like to study on what is the quality of vision, including the night vision, and also to understand if there was an improvement in their functional near vision. So basically, we decided to use 3 lenses. We went ahead with the Impress lens from the Hoya Surgicals. We decided to use Biotech Icryl Cert lens, and we decided to use the Vivity lens from Alcon. Each of them had their own proprietary technology for the EDOF effect. We dedicated 25 patients to the Vivity group, 25 patients to the Cert group, 25 patients to the Vivinex Impress group, and 25 patients we kept in the monofocal group, where we used it as a control group. As I told you, the purpose was to understand the quality of vision and if there was any degradation. Methodology, basically we decided to assess their vision at 1 week, 1 month and 6 months. We decided to assess their uncorrected distance vision, uncorrected intermediate and near vision. And we also decided to evaluate their visual performance using the NEI-RLQ questionnaire. I'll get on what is it in a little while. In inclusion criteria, basically we decided to take 18 years plus patients who had cataract. One thing we decided to do was we did not include any patient having more than 0.75 diopters of astigmatism. The reason being the Impress lenses did not have a toric version launched right now. So for the purpose of this study, we decided not to use any patients having astigmatism. In exclusion criteria, we decided not to use any patient or include any patient who would have any kind of maculopathy in whom any presbyopia correcting IOL was not advised. Again, here one thing to be noted was that we decided to go ahead and use these lenses in patients who had undergone refractive correction, whether it was a hyperopic or a myopic LASIK, but we decided to use these advanced monofocals in these patients also. So post-operative results, what we found was that the uncorrected distance vision was not significantly different in the advanced monofocal group as compared to the monofocal group, meaning the advanced monofocals performed equally well for distance vision. But what we were very happy with was that in case of the intermediate vision, the advanced monofocals almost provided N6 or 0.1 on logMAR as compared to 0.22 on the monofocal group or N12. Again, in case of the near vision, what we found out was that in the advanced monofocal group, the vision was almost 0.14 or N8 in adequate lighting, while in case of the monofocal group, it was only 0.33 or N18. This meant that the advanced monofocals distinctly outperformed the monofocals when it came to the functional near vision as well as the intermediate vision. When we talk about the groups, the 3 groups per se, what we found out was that the Alcon Vivity and the Icryl Cert performed very well at all levels. They offered excellent distant vision, intermediate vision, and very good functional near vision. In case of Impress, we had 2 points to note. One thing, if we found that there was any residual of more than minus 0.3, there was a loss of 1 line of distance visual acuity. And in case of intermediate and near vision, the Impress was 1 line less as compared to Alcon VVT and ICRIL CERT. Otherwise, all the 3 groups performed very well as compared to the monofocals. Again, when we plotted the defocus curve, as you can see clearly here in the blue line, which is showing the Impress, as you can see, at minus 0.5, you can see there is a slight dip in the vision. So this confirmed our doubt that any residual of more than minus 0.3 in case of Impress led to slight loss of vision. One more thing to understand is that all of these lenses had excellent defocus curve, meaning from plus 0.5 up to minus 0.5, the loss of visual acuity was not very significant. This meant that even in case of a slight surprise, the advanced monofocals performed very well and gave very good vision to the patients. We went ahead and showed these pictures to the patient, asking them if they had any glares, halos, or any starburst effect when they were driving at night. Most of the patients, up to 96.4% of the patients were very happy with the vision. Only 6% complained to us that they had halos and glares when they were using these lenses. As I told you, we understood the visual outcomes with NEI RLQ questionnaire, where there is a set of questionnaire. We have different questions like how difficult you have in reading paper, and you have to grade it from 1 to 5, 1 being no difficulty at all and 4 and 5 being very difficult. Similarly, you had questions like how difficulty do you have at driving at night. Based on this, we found out that most of the patients were very happy driving at night also. When it came to the functional near vision jobs like cooking, using computers, shaving, makeup, or seeing the dashboard in the cars, most of the patients reported that they were very happy or they were happy with the quality of vision. Towards the conclusion, I would like to just say that from our study and in our practice, we have decided that the advanced monofocals technically should be the choice in compared to monofocals in all the patients who are fit for presbyopia correcting lenses. Yes, we may not be able to use the trifocals for all the patients, but the advanced monofocals should be the next thing that we should use. Number 2, in our practice, what we normally do is we practice micro monovision. Meaning in the distant dominant eye, we use advanced monofocal and target it to ametropia, while in the near dominant eye, we make it minus 0.75 target so that they have very good distance, intermediate as well as near vision. We always advise our patient to use ample light while reading or doing near vision if they want to have good near vision. Again, halo and glare complaints were at par with monofocals. So basically, most of these lenses performed very well in all the settings and did not have any complaints like those of the trifocals. And according to us, ICRIL CERT is the best lens to be chosen out of the 3 because it offers a very good value for the amount of the lens. Thank you so much.
Excellent study. It is actually a neutral the way the companies come and say ours is the best lenses. So this is a nice way of presenting and giving an overview of different advanced monofocals. Very nice. Anybody would like to ask any questions on this? As we are short of time, otherwise we'll take at the end of